My name is Dr. Tirumala Naresh. I am working as intervention cardiologist, DBR Hospital, Tirupati. Today, I am going to speak on latest update in hypertension. And coming to the introduction, as per the WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to cardiovascular diseases, which affects 45% of the people in the age group of 40 to 69 group. Rising blood pressure is among the most important risk factor for cardiovascular diseases. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people, or 51% of the men and 41% of the women with hypertension, were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 in men and 1 in 4 in women with hypertension worldwide. International Society of Hypertension has released ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempt to address the issue that in resource-poor settings. Optimal care refers to the evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow the specification of essential standards of care for low resource settings. The AHA and ACC has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among the patient with low atherosclerotic coronary vascular disease risk. Among the low adults, that is no atherosclerotic coronary vascular disease or 10 years coronary vascular risk of less than 10%, with stage 1 hypertension, a blood pressure of 130 to 139 in systolic and 80 to 89 mm of mercury diastolic. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. And acute respiratory distress syndrome is a potentially fatal condition involving the lung damage, and experts often associate it with severe COVID-19. A recent study which appears in the Journal of American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS, and lowering systolic blood pressure targets down to the 110 mm of mercury to less than 130 mm of mercury range substantially reduce the cardiovascular adverse events in the step randomized trial, and affirming the sprint findings of an older Chinese population. Among some 88,500 patients aged between 60 to 80 in China, the intensive target trimmed 26% of the composite CVDs. Findings from a second major trial supporting the lower target could be unite the guidelines, whichever among the US professional societies range from the thresholds to 130 to 150 mm of mercury. With regard to the prognostic value, ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Society of Guidelines of the Management of Arterial Hypertension recommend that diagnosis of hypertension should not be dependent on office blood pressure measurements, but also on the out-of-office blood pressure measurements such as ambulatory blood pressure monitor or home blood pressure monitoring. 24 hours and nighttime blood pressure measurements were associated with greater risks of mortality and composite cardiovascular outcomes. Thus, they may be considered as the most relevant measurements of estimating CVDs. For every 20 systolic and 10 diastolic increment of blood pressure at night, the risk of mortality increased by 23% and risk of cardiovascular event rise by 36%. Most patients with hypertension requires lifelong medical therapy to achieve optimal blood pressure control. The 2018 European guidelines equally recommended 5 classes of antihypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to the therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower blood pressure targets, to start antihypertensive therapy with the initial dual fixed dose combination of ACE inhibitor or ARB plus calcium channel blocker or diuretic. Since early July 2018, the products containing valsartan have been recalled worldwide. The reason is detection of a known carcinogen, namely N-nitrosyl methylamine, which can be found in candesartan, irbesartan, losartan, and olmesartan, and valsartan. NDMA has been classified by the WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If the 1 lakh patients would have received NDMA contaminated valsartan every day for 6 years, in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they have taken the highest daily dose over the 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits plus 6%. The HYSIA study represents the largest study that tested nighttime antihypertensive treatment in this trial. The chronotherapy was associated with the significant reduction in the endpoints, including death. The HYSIA chronotherapy trial tested whether the nighttime therapy in comparison to the usual upon awakening hypertension therapy exerts a favorable CV reduction. The largest study included a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BP measurements was performed for 48 hours to collect the data on how BP different during the sleep. The risk reduction of CV events was significantly improved for the nighttime treatment when compared to the awakening treatment. Thank you.